art and humanities in medical education. To quote AAMC, academic medicine must continuously build and improve upon educational practices and environments to allow learners to provide optimal care for their patients, collaborate with their fellow healthcare professionals, and care for themselves. There's growing evidence that integrating humanities and arts within medical education curricula supports relational outcomes such as empathy, communication, cultural humility, and teamwork. Transformational outcomes at the level of professional identity formation and advocacy, and skills-based outcomes such as honing observation and interpretation skills. These are all outcomes valued by Geisinger. In addition, the humanities and arts can spark joy, enhance renewal, and restore meaning for each of us. I am pleased to introduce the National Endowment for the Humanities webinar series, Healthcare Ethics, Humanities, and Social Justice. This webinar series is produced by Geisinger Commonwealth School of Medicine in conjunction with Misericordia University with support from the National Endowment for the Humanities. Today, we have the first of 5 webinars entitled Social Justice and Advocacy in Medical Practice. I have the privilege to introduce our presenters. The first is Dr. Stacy Gallin. She's the founder and director of the Maimonides Institute for Medicine, Ethics, and the Holocaust, and the director of the Center for Human Dignity and Bioethics, Health and the Holocaust at Misericordia University. She is also a visiting assistant professor at the New York Medical College in the Biomedical Ethics and Humanities program. Dr. Gallin is the co-chair of the Department of Bioethics and the Holocaust and a faculty member for the Department of Education of the UNESCO Chair of Bioethics. She is also a contributing author for the Globe Post. Along with Davidson College star basketball player Kellen Grady, Dr. Gallin recently started a social justice initiative called College Athletes for Respect and Equality, with the goal of educating and empowering athlete activists to use their platform to help promote equality, justice, and tolerance for all people. In addition, she works closely with several national and internationally recognized organizations to raise awareness regarding the relevance of medicine, ethics, and the
on that. So, learn appropriate skills and abilities to provide care to individuals that are experiencing circumstances of social injustice that affect their health care. Going back to what I said earlier, when do you see a doctor? When you typically go see a doctor? You go and you see a doctor when you are experiencing some type of medical issue or you are vulnerable. You're in a vulnerable situation. So if you're already experiencing some type of vulnerability, now you're adding to that individuals that are experiencing circumstances of social vulnerability. And how does that affect their health care? And how does that affect where they are when they're coming to see you as a healthcare professional? That's something that needs to be understood in order to improve the relationship. And then third, understanding the responsibility to advocate on multiple dimensions as part of your professional duty and acquiring the necessary skills to do so. So it's really a tiered approach in terms of what healthcare professionals have to do. Next slide, please. Thank you. So this is an incredibly brief overview of race in the United States, right? I think you're even looking at the slide and you're going, are you kidding me? Right? Because obviously this is not something, we couldn't cover this in one slide. We couldn't cover this in an entire presentation, an entire series, an entire course. The only reason, obviously, we also can't ignore it, right? We also can't ignore the fact that this is something that we at least need to touch on as it pertains to the larger topic that we're discussing today. So what I did here was just really add in the bare minimum of what needs to be covered in terms of, as I said, this larger topic. So also we have a slide at the end that has resources in it. So everything that I'm using here today is coming from the articles that you'll see at the end. So race, the social category that captures differential access to power and desirable resources in society. There's a lot of different definitions that you can find that talk about race. I chose this one, and the reason I chose this one is because it does incorporate the idea of society, right? And that race has these aspects of power and how that impacts somebody and where they sit in society and what they have access to in society. Because when you talk about where they sit and what they have access to in society, medicine is an institution within society. So in the same way that we talk about, systemic institutional racism, just like that applies in other categories, that applies when we're talking about medical practice as well. Racism, organized system rooted in an ideology of inferiority that categorizes, ranks, and differentially allocates societal resources to human population groups. Again, why did I pick this one? And keep in mind, again, this is all subjective, right? I chose to use these definitions. There are other definitions that could be used again. Why did I choose this one? Again, it's focusing on the idea that this is systemic, right? It's something that is kind of coming from top down, right? And it's rooted in this ideology of inferiority. And the important word to me here is the idea of categorizing. We're categorizing people. And, we're all everybody's coming from, and this is something that we talked about before, everyone has their own professional, personal biases. So my professional bias comes from the fact that my background is in bioethics and the Holocaust. So the idea of labeling, categorizing, and persecuting people based on their race, based on whether they're fit or unfit, that's something that comes up a lot in bioethics and the Holocaust. So the idea here that we are saying certain people are inferior, we're categorizing them, we're ranking them, and we are allocating resources to people based on that. That's really important. And throughout US history, we've seen non-dominant racial groups have, either by law or custom, received inferior treatment in major societal institutions, including medicine. So we can't ignore that. We can't just pretend it doesn't exist, because it does. And so in order to understand racial disparities in medicine, you really have to understand the ways in which racism affects other societal institutions. Medicine does not exist in a vacuum. It exists in the larger society. It exists within this culture that we all live in. And so even though I'm saying before that, the bullet point before saying that, pointing out that yes, we have racism in medicine, that's just one subset of all of these other societal institutions that racism exists in. Next slide, please. So, history of racism in medicine. Okay, again, this is just me taking out one thing, just one brief, super tiny example to use, because otherwise we would be here for a very long time. History of racism in medicine. You see the quote on the top, Dr. Damon Tweedy. If you have not read his work, I highly recommend it. Black Man in a White Coat is an absolutely unbelievable book that I really recommend. Medicine, like other institutions in society, is now being called to task by its own for the role it has played in perpetuating the long-standing inequities that have led us to this moment. Okay. I can't go through the history of racism in medicine. It's very long, right? What I can tell you is, and again, this is coming from my own personal professional, bias, what I do, for a living in terms of bioethics in the Holocaust. After the Holocaust, after we found out what the medical profession was doing and these crimes against humanity and these horrible abrogations of ethics that were taking place, the Nuremberg Code was published and in 1947. And what was said here in the United States by physicians here in the United States was, quote, "It's a good code for barbarians, but an unnecessary code for ordinary physicians." Because in the United States, we wanted nothing to do with this crazy science, quote unquote, these mad scientists and doctors and what they were doing over there. That's not us. We're not doing that. We're not participating in that, okay? However, at the exact same time, the Tuskegee syphilis experiment is happening here in the United States, right? Between 1932 and 1972. And in fact, in 1945, penicillin is determined to be the treatment of choice for syphilis. And in 1947, okay, no, August 1947, and then 1947, the United States Public Health Service establishes rapid treatment centers where they give people with syphilis penicillin, but they deny treatment 2 men in this study. Those men were Black men, okay? So we can see that even though nope, it's not us. So the idea of reckoning with our past, the idea of reckoning with the institutional racism, the history of racism in medicine is very, very difficult. Next slide, please. Okay, COVID-19, again, this is really what's allowing us at this moment in time to kind of re-examine this. We can see that the death rate for COVID-19 is 2.1 times higher for Black people than for non-Hispanic white people. In June of 2019, and as I said, the resources for most of what I'm giving you is on the last slide. I put the resource for this right on this page because I could see people going, nah, no way this really happened. But it did, because you can see the link to the article. June 2019, an Ohio physician and politician publicly suggested that higher rates of COVID-19 could be attributed to Black people not washing their hands enough. That's an actual story from a couple of months ago. This man is a physician and a politician. This came from an op-ed that Dr. Tweedy wrote. A more nuanced approach, informed by public health, leads to exploring the real underlying reasons the coronavirus has caused more destruction in Black communities. Crowded, multi-generational housing arrangements, more frequent use of public transportation, and employment in newly hazardous frontline service jobs. So there are things that aren't specifically only related to medicine in the way that I think most people would think. They are part of this larger system. When we talk about, housing, and we're talking about the need to take public transportation or to take certain jobs that are frontline service jobs that have more exposure to COVID-19, right? The other thing that I would add to that is that, we've seen a lot of COVID-19 guidelines for the allocation of scarce resources. Some use comorbidities as an exclusionary criteria. So they say, well, people with diabetes or heart disease, things like that, they're more likely to die from COVID-19. So, perhaps we should take that into account when we're creating these guidelines. African Americans are more likely to suffer from diabetes than non-Hispanic white people. However, if you look at the studies, first of all, what we see is that people that have diabetes, if their diabetes is under control, then they become the same as just people without diabetes in terms of their response to COVID-19. So what we really need is long-term preventative wellness-oriented community healthcare in order to kind of give these people the same access to healthcare so that we're not creating this kind of group of people that has these comorbidities in the first place. That's something that we should have been doing all along, but we haven't been doing. And now again, COVID-19 is highlighting this. Next slide, please. So structural competency, that's what we need to be, really understanding at this point, which emphasizes the diagnostic recognition of the economic and political conditions that produce health inequities in the first place. And it calls on our healthcare providers not only to recognize how institutions, markets, or healthcare delivery systems shape symptom presentations, but also to mobilize for the correction of these inequities in society. Because we have racial disparities in healthcare, they can't change until the health system changes. We have to change the way we teach and understand the interplay between race, social justice, and health if we want to see, these larger changes take place. Next slide, please. So that has to happen on both the micro level and the macro level, so both the individual level and the community level. And they can only be understood in relation to each other. Racial disparities in healthcare occur within a larger system of discrimination that's supported by institutional policies and unconscious bias. So this is what we mean when we talk about institutionalized systemic health inequities. Health inequities, differences in health that are unnecessary, unavoidable, unfair, and unjust, and affect the quality, you're fine, affect the quality and the quantity of healthcare. Next slide. So we see chronic disease, injuries, and infant mortality in developed countries follow a social gradient according to which an individual's socioeconomic position, the lower an individual's socioeconomic position, the more likely he or she is to be in poor health. So as you're seeing, there are a lot of connections that are being made here that we really need to understand. Some communities are exposed to difficult social, economic, and or environmental conditions that may result in health problems. So there is this very, very close connection between social inequities and health inequities. So we see this all coming from so many different places: education, employment, housing, criminal justice system. And what that's leading to is difficulties in accessing healthcare on a societal level, a lack of parity regarding quantity and quality of available healthcare on a community level, and a lack of government policies guaranteeing affordable healthcare to every citizen. So that's the national level. So we started here with the macro, top down, and now we're going to hit the micro. Next slide, please. What are we talking about? We're talking about the micro level. We're talking about things that you as healthcare practitioners probably deal with a lot more. So we're talking about health literacy, right? What do your patients know? What do they understand when you are speaking to them about their conditions, about their risk factors, about their treatments, personal autonomy. Again, we talk about informed consent. This is what we're talking about: the capacity and liberty to choose to seek care, knowledge about healthcare options and individual rights. People in vulnerable communities often have to deal with long wait times and complex bureaucratic procedures that are involved with the medical visits. And just in general, a failure to treat patients with dignity and respect based on either conscious or unconscious biases. So these are all the things that, that we're dealing with that really can cause an issue on both the micro and the macro level. So next slide, please. So why do we need to learn about this, right? Now that we've gone through kind of all of these different things, why is this important? The classical biomedical models that we are using within medical education don't really account for social vulnerabilities and health inequities. We don't really have a standardized curriculum that goes over all of these things. And in order to truly advocate for our patients at the micro and macro levels, we have to have an education. We need to take these factors into account. We need to introduce less stigmatizing approaches to healthcare practice. It's based on the concepts of listening, patience, openness, empathy, and respect for the dignity of the human being as a whole, understanding what their life circumstances are like so that when they walk into your office or they, you kind of have an understanding of them as a whole person. And in order to do this, it's essential to reflect on the prejudices and misrepresentations about social vulnerability and its implications. We've already seen there's racism and prejudice in the general population. That's no different in healthcare. And we all have unconscious bias and prejudice that can affect practice and policy. If we aren't willing to kind of look inside of ourselves and see what those unconscious biases and prejudices might be, then we really are unable to take the next steps. And that leads us to Professor Ellman's portion and the activity that she wants to share with you.
Thanks, Stacy. So first we're going to just kind of do a little bit of a poll. This should be coming up. Again, all of these are anonymous. But from the section, why now? Which reasons resonate most with you all, if you wouldn't mind taking a second to answer the poll. I know you guys thought you could sleep through this, but we're making you be active. All right, so it looks like 43% resonate most with longstanding issues of social justice within our country that have been highlighted or exacerbated within the past 6 months. And one more poll. Oops, that's not what I wanted to do. What are you seeing now, Stacy?
I see you were, okay. Back to the, now you're good on polling 2.
Okay,
But nope, we're still on question 1.
right. Here we go. So why do we need to learn about this? What do you think the top reason is based on what Stacy discussed? It does look like a lot of people are paying attention.
It's a close one too.
Very exciting. All right, I'll end it now. All right, so 37% that in order to truly advocate for our patients at the micro and macro levels, we must take these factors into account. Well, thank you guys for your participation with this small activity. What I want to talk to you guys about is something that you can do a little bit later. We don't have enough time to do it today, but many of you probably know, or if you don't, Project Implicit, and now there's another branch called Project Implicit Health. It's a nonprofit.
Carly, you just have to close out the poll so that people can see the.
Do you see it now?
Now we don't see, the poll is still on there, but we don't see the actual PowerPoint.
Okay, hold on. How about now?
Nope. You still have the poll up?
Okay.
I think you need to X out the poll.
I don't have the poll anymore.
Oh, we're good.
Got it?
Okay. Yep, you're good. Now you just have to get back to your slide.
All right. Just making sure everyone's paying attention. Okay, how's that?
Now you just have to make it, there you go.
All right.
Thank you for bearing with us as we navigate technology.
All right, so it's a nonprofit organization that it collaborates interested those that want to look into implicit social cognition, thoughts and feelings outside of our awareness. So we really need to learn about this because of the unconscious bias and prejudice that can affect our practice and policy. So this is one way that you can do this. It takes 15 minutes, and now this Project Implicit Health is just focused on depression, anxiety, alcoholism, but Project Implicit itself talks about weight, race, gender, and it's a really good way to take a really good look at yourself and see, what am I doing when I come into these situations? What am I bringing that I just don't even know about? And then that obviously goes back to what Dr. Gallin talked about, but it also goes into what advocacy is. So she talks about, what we have going on and how do we deal with it. Well, advocacy is one way that we can deal with it. And for healthcare providers, physicians, we talk a lot, and, social workers, nurses, physicians assistants. Advocacy is a part of professionalism. It is a fundamental competency. And a proposed definition of healthcare professional advocacy should integrate both individual and societal facets. Now, I'm not going to read you this quote, but basically it's saying that it is our duty to promote the social and economic, educational, and political changes for our clients. Now, the core of advocacy is undertaking the necessary actions to bring about positive change. So we are in this we have a unique opportunity. We get to build relationships with our patients and our clients, and then we can do something about it. And again, we'll talk about this in a few minutes, but we can do it great on an individual level, but we can also do it. I forgot I was in charge of the moving it on. We can do it in the patient level, the practice level, or the community and system level. Now, let me say something really important. These are not mutually exclusive. You can do all of them. You can do one of them. You can do 1 and 3. You can do 2 and 3. However best you feel comfortable advocating, that is what you can do. So on a patient level, these activities are focused on individual patients in the clinical setting with the immediate medical or social health needs. Okay, so this is, maybe getting your patient in communication with a social worker or someone else to help them with housing or help them get on SSD or SSI. So that is that individual advocacy. The practice level includes addressing the societal and social inequalities, whereas we can make changes within the population. And then community and system level is this activism with the goal of creating lasting change so that we can make for a better community and society. So again, now if we bring it back to advocacy within medical practice, improving health implies a responsibility to promote health equality in response to the needs of the vulnerable or marginalized populations. All healthcare providers, this is what we promise to do when we get into these fields, right? So something happens at some point where we maybe just get sidetracked. We're so busy, right? We forget that this advocacy is so important. And we're reminded of that, particularly today with COVID-19. And I know Dr. Gallin wanted to mention a little bit something here, I believe.
Yeah, I just wanted to say, when we talk about the tension between the needs of the individual and the unintended consequences that those needs may cause to others in the community. So, COVID-19, I think, has really, again, obviously can't be said enough, thrown everybody for a loop, particularly those in the field of healthcare. So when we're talking about kind of coming up with these plans, what are we going to do if we have to allocate scarce resources? Healthcare practitioners are being asked to, do something where really instead of putting the needs of their patient first and being able to advocate for their patient, instead they're being asked to figure out, well, what do we do, what's best for society, kind of this utilitarian approach to things, because we only have so much of something, whether it's ventilators or PPE. That's really created a tension that we have not seen before. I think traditionally the role of medicine, again, goes back to the idea of the provider-patient dyad and the idea of first do no harm. And it can be hard to figure out kind of how you add on to that, this idea of how can I care and do what's best for my patient, but also advocate for society and do it in a way where these two things aren't bumping up against one another. Just in the interest of using COVID-19 as the example throughout this entire presentation, we just wanted to point that out here as well. So thanks, Carly.
Yep. So again, what can we do? As Stacy mentioned earlier, a lot of our resources are at the back on one of our last slides, and those can be really helpful. But just for the sake of time, we picked a few things here. So we can realize that many physicians come from a position of privilege and may hold unconscious biases that can affect their practice. And I know this is so hard to admit. We don't want to think that we're biased. We don't want to think that, we don't act the way that's congruent with the way that we talk or what we do. But the truth is we all have it. And that's why going back to that take-home activity can be essential. You can realize like, oh, wow, this is something that I didn't realize that I believe, right? And then when people walk into our office or our office, we can, recognize, okay, I need to take account for this and deal with it, make sure I deal with it accordingly. We can recognize that medical school curriculums remain focused on biomedical instruction. So again, if this is a competency of physicians, if advocacy is something that we need to do, we need to make sure that we're teaching it in our classrooms today. Expand curricula to incorporate implicit bias and social factors that influence health of diverse patient groups. Again, we can make sure that we're teaching about implicit bias and how to recognize it. We can train and evaluate and hold physician educators accountable, and we can model the behaviors we wish to encourage and take on a mentorship role. This is so key. We are all looked up to, doesn't matter what our profession is. And so if we talk the talk and walk the walk, people will notice and people will follow. But we need to know that people are always watching, and it's really important. If we're telling people you need to advocate, then we need to do it as well. So we need to advocate for advocacy. Again, we talk a lot about it, but sometimes it gets forgotten. So we need to advocate for financial and policy reform. If our clients or patients aren't able to pay, well, maybe we need to get things up. We need to start advocating on a higher level, and not just on the individual level where we're helping the one patient. We maybe need to make it to the larger society or community level. We need to create educational programs like this to address the topics of racial disparities and social inequalities in healthcare, right? So it's great when we're helping on that individual level, and that's one way to advocate. But again, let's make it bigger. Let's make change. Petition for funding to address social inequalities, address selection criteria for medical schools to emphasize social justice, to make sure that we're including everyone and hearing all different sides of the story. And offer medical students immersion service learning experiences that highlight the issues of social justice in community-based settings. And I know that's something that we're doing here at Geisinger Commonwealth School of Medicine. We are really having them get into the communities and bring service learning to the forefront. So a few more polling questions for you guys. Let's see how I can do here. So, is advocacy part of your current practice, would you say, at this point? Oh, no. My battery's running low on my computer. All right, wow, it looks like 77% of you say yes. That's amazing. Maybe at the end we can hear a little bit more about how people are advocating in their current positions. Do you feel it is important to incorporate advocacy into medical practice? And yes, we are at 98%. And last but not least, and then I will turn it over to Dr. Gallin here. Which level of advocacy, patient level, practice level, or community system level, do you feel most comfortable incorporating into your work? All right, so it looks like patient level came in first. So again, just some activities some questions, food for thought in terms of, what am I doing? Can I be doing it? And where do I feel most comfortable after learning more about this today?
So again, this is our last slide that we want to end on. A profession sworn to heal can no longer passively accept the inequities it has witnessed for decades or the hand that it has played in them. This is not, as I said earlier, this is not meant as a judgment. This is not meant as a slap on the wrist. I think one of the things that we've all realized over the past 6 months, if not earlier than that, is, we live in a broken system. We live in a broken world. And we all have a responsibility to do something to make that better. You see the photo on the right-hand side of the screen that says "What You Do Matters." This is taken from a campaign that was launched by the United States Holocaust Memorial Museum a few years ago. And when I went down there, I was really struck by that, because I think the point that they're trying to make is sometimes, in particular, the concept of advocacy can seem to be very intimidating. How can you fix this broken system? How can you fix, we're talking about, these historical inequities that have been going on for so long. But everybody can do something, right? And whatever that is, whether that's something, that you're doing in your own individual practice, working with your own clients or patients, or that's something that you're doing on a more systemic level, whatever it is, the question that we really want to leave you with today is, what will you do to promote social justice and advocacy in medical practice? And we hope that that is something that you think about, that even after we end our webinar, that's something that's you really spend some time with, because if we want to make the world a better place, we really have to start by looking inwards and figuring out what we can do. So Carly, if you'll just go to the next slide for a second. So these are the resources that we spoke about before. I realize that we are putting these things up very quickly. If anyone has any questions, I did put the link to Project Implicit in the chat for you. But if anybody wants, these specific resources, we can definitely email them to you. Carly, can you go to the next slide, please? Okay. So special thanks to everybody that made this possible. We really appreciate everybody. We do have a planning committee that we've been working with for all of these webinars, who have been essential in putting together all of these webinars. As we said, this is the first in a series of 5 webinars. And it has been a joint project between Geisinger and Misericordia that's sponsored, funded by the National Endowment for the Humanities. So thank you very much to everyone who's made that possible. And just the final slide right here, if we could, Carly. Our next webinar, International Medical Ethics in the Wake of COVID-19, will be held on Thursday, October 29th at 12:00 p.m. If you haven't registered for that, please do. You'll also see here our email addresses if you have any questions for us, or you want to reach us. I think we saw in the chat, we need to, in order for the activity to be thoroughly evaluated and CMEs, all that stuff, you do have to fill out that questionnaire. If anyone has a question, we have about 5 minutes left. So if anybody has a question, or if you want to talk about the way in which you're incorporating advocacy into what you're doing, or anything like that, please feel free to message Mary, and she can unmute you, or.
And just a reminder, if you are getting CME or CEU credit, you need to sign out again now at the end. I know most of you signed in the beginning, but you do need to be here for the full length of the webinar to get that credit, as well as fill out that evaluation, and then information will be sent to you. There is one document here that we can also get to you. So this is the regularly scheduled series document form from our Center for Continuing Professional Development. We have it available if you want it. You can just, again, email us or put it in the chat. Are there any questions or comments coming through, Mary?
None so far. I just have one comment, and I think it's, it's a personal reflection of working with our students the last, I guess, 6 months, and really trying to educate myself more in terms of the racism that continues, has occurred and continues to occur. And I think for many of us, it's so humbling, and it's, it's living truly the lifelong learner and being able to reconcile what I didn't know, trying to learn it, and then also advocate for students and the community at large. And I think we have to acknowledge our own struggles in working through all of that.
Yeah, that's a really great point. Thank you. I think that's part of the challenge. And I think also something, part of what I was trying to say is, there's really, the purpose is not to place blame, because I think when you start kind of placing blame, it can make it very difficult. It can make it very difficult to go on this journey. And I think that it's really important that we all feel comfortable going on this journey. We all feel comfortable being able to ask questions and get information. And again, to be able to do that in an environment that is respectful, where we feel like we can exchange ideas and just be very honest and open. That's something that I think, unfortunately, can be very hard to do today. So that's what we're trying to do here, is really to start a conversation and provide some information. And, you know, hopefully if anyone's interested in, you know, doing something like this or continuing these kinds of conversations, again, please feel free to contact us. It's really our goal to be able to, you know, get this out to as many people as possible. So we're more than happy to help anyone else who's interested in doing something like this. Will this recording be disseminated in a few days? Carly, do you have the answer to that?
The answer is no. We will be working on getting that available. We are trying to see if the recording could be available for CMEs and CEUs, but some stuff needs to be done on our back end for that. But we will certainly, we have everyone's email addresses, and we will do our best to get it out.
So just so you know, we really, really want the information to get out to as many people as possible. You know, sometimes there could be some issues just because of, you know, accreditation with CME and things like that. So we're going to work as hard as we can to try, you know, work with the CME and things like that. But it's not for a lack of wanting to get this information to you. So we're going to do our best. And as Carly said, we'll keep you posted as much as we can and try and work with the appropriate accreditation people to make sure that we can get this to you. But if you do have specific questions, we can certainly get you like a slide or two if you need that. That would definitely be possible. Or if you need a resource or two, that's definitely something we can do.
There is a question here about what are student groups or organizations that advocate and discuss these issues, such as white coats for Black lives. I would love to be involved and present on these issues as well. That's wonderful. I think that's something that maybe we could discuss offline and see how we can work together to do that.
I think there's a couple of minutes left. I think there was somebody that wanted to ask a question themselves.
Okay. Are they able to unmute?
They should be able to.
They should be able to.
Technology, gotta love it.
Leaving us in suspense.
Yes, I know.
Hi, my name's Tim Farrell, and I'm one of the 4th medical students from GCSOM. And thank you so much for putting on this webinar. I really appreciate it, and I think it's very important to discuss this. My question for everyone is, I feel like, as was kind of alluded to in the presentation, that Geisinger has done an excellent job at training us to recognize healthcare inequalities, social injustices, recognizing our own implicit biases, and, you know, discussing microaggressions and all that stuff. And I think it's really like integral and something that I've talked about on my residency interview rotations since I've been on the interview trail. So I guess my question is, do you think that this is going to improve just in sort of the intrinsic nature that now medical schools are recognizing this, or do you see this more as kind of like a problem that can be locked into practice just because of the dynamic, as some of the older generations of physicians may have not had this training as an integral part of their medical school training?
Yeah, Tim, first of all, thanks for participating. We appreciate it. I definitely see this as something that is going to change. I've been really pleased. I work with several medical schools, and I've been really pleased with the responses that I've gotten recently. I do see a desire among not only the students, but the faculty and administration as well, to incorporate programs and courses and seminars on this topic, which it makes me feel really hopeful and optimistic. So I do think that it's something that's going to change, and I think that the way it's going to change is with advocacy, and that's why we wanted to incorporate advocacy into the very first seminar. Is advocacy is something that is not only helpful in individual medical practice, but it's helpful in terms of medical education as well. If we kind of, everything kind of rests on, it's like a pyramid, and everything rests on the step before it. And we can't really talk about this without actually being able to be knowledgeable, right? We need knowledgeable people. We need to train the trainers. So I do feel hopeful that this is something that we're going to see a change in. And I also think that with the ability to do virtual programs like this, although in fairness, there are people that can do technology better than we can. Carly's done an excellent job. I am not great with technology. But I do think that, it'll make programs like this more accessible. And I think that's fantastic as well.
Yeah, and thanks, Tim. I think, first of all, I appreciate you recognizing that it is very important at Geisinger Commonwealth School of Medicine, and that I'm glad you had a positive experience with it. And I would agree with Dr. Gallin that I think these are, the fact that it is being implemented, it looks like one of our attendees today said that it is a requirement for all providers, where she is. So I think we are taking those steps to get there. But, the more we all get involved and do events like this, the better it'll be.
So unfortunately, it's 1:01. So I think we have to wrap it up. Thank you so much to both Professor Ellman and Dr. Gallin. I think this was a great first webinar on our series 5, and we will be looking forward to the ones in the future. Thanks, everybody.
Thank you very much, everyone. We really appreciate it.